Morning, everyone. Welcome to the Carsey Policy Hour, and thank you for joining us this morning. I'm your host, Melinda Negron-Gonzalez, and it's a pleasure to welcome you to today's discussion on one of the most consequential policy developments in recent years, the Reconciliation Law, also referred to as the One Big Beautiful Bill Act. For those of you joining us for the first time, the Carsey Policy Hour is a monthly conversation series hosted by the Carsey School of Public Policy at the University of New Hampshire. Each month, we bring together policymakers, practitioners, and community members to explore the issues shaping New Hampshire and beyond. The Carsey School is independent and nonpartisan. The school is nationally recognized for rigorous and actionable research, housing 4 research centers, and the Carsey School educates tomorrow's leaders through its professional master's programs offered both online and in person. Do check out our website for more information on the Carsey School. I should mention and send a thank you to our series partners for the Carsey Policy Hour. Our series partners are the New Hampshire Municipal Association, New Hampshire's Bureau of Education and Training, the New England Sustainability Network, and the New Hampshire Association of Counties. Okay. Our presenter today is Deborah Fournier, JD, and Director of Health Policy and Law at the UNH Institute for Health Policy and Practice. Deborah's work bridges policy analysis, legal interpretation, and health system reform, and she has more than 20 years' experience translating complex federal and state legislation into actionable insights for policymakers, practitioners, and advocates. In today's talk, called Select Provisions of the Reconciliation Law, or OBBBA, Deborah will examine key components of the legislation in all of its complexity, including changes to Medicaid eligibility, financing, and provider payments, higher education, changes, alterations to SNAP and Medicare access, and more. Her analysis will also highlight what these changes could mean for New Hampshire's health systems and vulnerable populations in the years ahead. Following her presentation, we'll open the floor for questions and discussion. But in the meantime, while she is telling us about the OBBBA, do feel free to submit your comments and questions during the presentation using the chat feature. And you'll find the chat button on the center left of your Teams screen. The chat is open and it's visible to everyone as if we were sitting in the same room together having a discussion over coffee this morning. So I do ask, in the spirit of civil discussion, please avoid inflammatory remarks and do identify yourself in the chat when you offer remarks or pose questions. So without further delay, here is Deborah Fournier. Welcome to the Carsey Policy Hour, and feel free to share your screen.
Thank you. Hi, everyone. Good morning. Thanks for having me, Carsey. Welcome, everyone. My name is Deb Fournier. I am the Director of Health Law and Policy at UNH's Institute for Health Policy and Practice. And I'm going to walk us through a fairly high-level examination of OBBBA with a heavy emphasis on health access. So let's just dig right in. So what is OBBA? So this is a statute that was passed on July 4th of this year, and it is full of tax cuts, things that impact health access, food assistance, immigration enforcement, and higher education. And it is primarily a tax cut bill. And in order to pay for those tax cuts, and a few newer spending priorities, there were some anticipated and scheduled reductions in federal spending, and we'll talk about those. But the values of the tax cuts and the values of the subsequent reductions in federal spending are here on your screen. So the tax cuts were made permanent. They had been initially created in 2017, and they total more than $5 trillion with a T. It also increases some immigration enforcement spending by another $150 billion. And then, so in order to pay for all of those initiatives, there are some elimination of energy initiatives that are projected to reduce federal spending by $540 billion, some changes to how higher education funding happens, which is another $295 billion. Medicaid funding is reduced by $990 billion, and federal funding for food assistance, which is frequently known as SNAP, Supplemental Nutritional Assistance Program, gets a reduction projected to be about 20% or $180 billion. So we talked a little bit about the tax provisions, the health access, and we'll talk about more of this later in the presentation. The reduction to access to Medicare and Medicaid are essentially the following. The changes to Medicare essentially make it harder for lower income enrollees to access something called a Medicare Savings Program, which helps lower income Medicare enrollees cover the cost of premiums and cost sharing. It also eliminates outright Medicare eligibility for people with lawful immigration status. People without lawful immigration status are not offered Medicare or Medicaid for that fact. The changes to Medicaid, and we'll review what Medicaid is shortly. It essentially frustrates enrollment, and so it reduces access to Medicare aid through imposing work requirements, more frequent eligibility checks, increasing some cost sharing, and then it also ends Medicaid coverage for many legally present immigrant populations. And in addition to those enrollee-facing changes, there are also limitations placed on how a state, the options it has for financing its proportion of the Medicaid program, and it limits provider payments in important ways, which all put financial pressure on the Medicaid program. So just to put a capstone on it, Medicaid changes that were enacted make it harder for people to get and stay enrolled in Medicaid, and it makes it harder to pay providers and harder for the state to generate the non-federal share. The food assistance changes amount to what is roughly projected to be a 20% reduction in the SNAP program. States will become increasingly financially responsible for operation of the SNAP program. Currently, it pays 50% of administrative costs. It will go up to 75% of administrative cost. And New Hampshire will roughly be expected to pay about $8 million in SNAP by 2028. Prior to this, New Hampshire didn't pay anything for non-administrative cost for its SNAP program. Future benefits or future benefit increases are capped and tied to overall consumer inflation. And all future changes are required to be cost neutral, which means they don't cost the federal government anything more and they don't cost the federal government anything less. There are already work requirements in the SNAP program, but the work requirements are now expanded and extend to those who are in some of the upper income ranges, those who are 55 to 64, folks with children who are at least 14 years old, veterans, former foster youth, and people who are homeless. And if an enrollee at any time in a 36-month span has 3 months of non-compliance with the work requirement, then they can be disenrolled. And essentially, the requirements are 20 hours per week in a month of work or training activities. And some early estimates suggest that roughly 4,000 people, 4,000 additional people in New Hampshire would be subject to these expanded work requirements in SNAP. Okay, so now we're going to turn our attention to Medicaid. And I know I even fouled up and called Medicaid Medicare. It's easy to confuse them. So we're going to quickly cover what is Medicaid. So Medicaid is a publicly funded public health insurance program, primarily for low-income people. And there's three things that I really want you to remember about Medicaid. And that is, a Medicaid program is not mandatory for states, it's elective. But if you do choose, if a state does choose to run a Medicaid program, there are certain federal requirements that the state has to follow. And then in return for following those requirements, the federal government always pays a fixed percentage of the cost. And that fixed percentage is never less than 50%, 50%. Sometimes it is far more. So in terms of who offers Medicaid right now, currently every state in the union has elected to have one. And as I said, states, if they choose to go forward with a Medicaid program, essentially have to accept the federal terms. And the federal terms, broadly read, are that there are certain groups of people called mandatory populations and certain groups of services known as mandatory services that a state Medicaid program has to cover in order to receive the federal match. Then there are also optional groups of people that the program can cover and optional services that a program can cover and still receive a federal match for those people and for those services also. And in return for doing the minimums, covering the mandatory populations and providing those mandatory populations, the mandatory services, the federal government pays the fixed percentage of the cost. And it's frequently referred to as FMAP, the Federal Medical Assistance Percentage. It's based on the relative wealth of the state, the overall FMAP percentage. And because New Hampshire is a relatively per capita wealthy state, it's fixed, or its baseline, I should say. FMAP rate is 50%. It can be more depending on the service or depending on the population. The fixed percentage financing from the federal government protects the financing of the program by ensuring that no matter what happens that might increase enrollment, such as an AIDS epidemic or the Great Recession or a worldwide pandemic, there is always a guaranteed amount of federal financial support. So it is intended to work countercyclically so that when things are tough, people lose their work, which in the United States has historically and culturally been the primary way through which we offer citizens health insurance, that the program can expand and that the federal financial support expands with it to meet the need. So let's take a look at what Medicaid looks like in New Hampshire in terms of how many people are we talking about and what kind of folks are they? So Medicaid is dominated by children. You can see here that they are the single largest slice of the pie. They represent about 46% of the entire Medicaid pie in New Hampshire. Older adults and adults with disabilities who are fairly complex and can be fairly fragile are only 13% of the population. And then expansion adults, and we'll talk about them more later, are the low-income adults they don't fit into any other category. They're not a kid, they're not a pregnant woman, they're not a senior citizen or a person with a disability. Are the remaining adults that are covered. Most of the enrollment frustration changes that we're going to talk about are focused on the light blue slice, on the expansion adults, the 32% of the pie. But that's not all of the changes to Medicaid, but in terms of those that are enrollee facing, they are primarily focused on that 32% of the pie. So historically, expansion gets a lot of attention because Medicaid was created in 1965 and along at the same time as Medicare, and was created to cover these general 4 groups of people: infants and children, expectant mothers, older adults, people who are 65 and older, and people with disabilities. So in a country in which health insurance is primarily connected to employment, a program was created in 1965 for folks who at that time were not expected to work, culturally or in some instances legally. So expansion was something that was the expansion adults, this light blue slice right here, was introduced through the Affordable Care Act because low-income adults with no other qualifying condition were the only folks not on this list. On this chart, you will see the sort of Byzantine approach to eligibility that is Medicaid, which means that there isn't one income range that would make anyone eligible for Medicaid. The income eligibility ranges vary depending on the other characteristics of the people in the category. And what I want to point you to is that we have very generous income eligibility for babies and children, and more generous for people with disabilities who are working. Expectant women, we have generous but less than generous for children income eligibility, people with breast and cervical cancer, and then in the yellow is the low income adults. So these are people 19 to 64 with incomes roughly up to 138% of the federal poverty level, which in 2025 for a household of 1 is someone who earns $21,597. What I think is relevant and will be relevant when thinking about the work requirement, because often work requirements are posed as a way to diminish the need for Medicaid, because the idea is that if people were working, they would be making too much money to qualify for Medicaid. For the low income adult category, 21,597 is more than what someone earns if they are working a minimum wage job every full time, every week, and every week of the year, because that arithmetic adds up to $15,080. And the 100% of the federal poverty level is $15,650. So it's important to recognize that many of the people who will be subject to the work requirement could very easily and probably are already working. Okay, so expansion adults get a lot of attention because they are the newest Medicaid coverage population. Remember when we talked about FMAP, and I said that the fixed percentage is always at least 50 for New Hampshire, but sometimes it's more. In order to encourage states to grease the wheels for states to cover this group of people in their Medicaid programs. The FMAP for this group is 90-10, meaning the federal government pays 90% of the service cost for covering this group of people, which is, from a federal spending perspective, why so much attention is focused on expansion, because the federal government pays the vast majority of the cost for that program. Okay, so in New Hampshire, where do Medicaid folks live? Well, they live in every single county and in all but one county, which is Rockingham County. Medicaid members constitute more than 10% of the population. The one county, Rockingham County, is getting awful close. 9% of its population is covered by Medicaid. These three maps are broken out by the kinds of Medicaid populations that are covered. So traditionally, when we're thinking about Medicaid before expansion, that's called standard Medicaid, right? Moms and kids, people with disabilities, older adults. Granite Advantage is the brand name, essentially, of the program for the expansion in New Hampshire. So the far left map is the standard Medicaid programs as a percentage of the total populations in those counties. The middle map is the expansion program as a percent of population in those counties. And the far right map is the total of the two as a percentage of the total population of the county. So it is in every county for every program. Meaning, in other words, for every type of eligibility group. Relative to other states, New Hampshire covers about 13% of the state population through its Medicaid program, which relative to other states is a relatively small percentage. There are two other states, North Dakota and Utah, cover smaller percentages of their overall population with Medicaid than New Hampshire does. Okay. So we're going to turn our attention back to what the reconciliation law, or OBA, does to change Medicaid. And it does it in two really significant ways. It frustrates enrollment, and we'll talk about that in a minute. And it limits resources to fund the program. And we'll talk about that in a minute too. So the mechanisms that are used to frustrate enrollment are work requirements, more frequent eligibility checks, an increase of cost sharing, and then an ending of eligibility for not all, but many legally present immigrant populations. The limits to state financing and provider payments are limits on provider taxes, what kinds can be generated in order to contribute to the non-federal share, because it's jointly funded between the federal government and the state. So the federal government always pays at least half. That means the state has to generate the non-federal share. And there are rules about how a state can generate the non-federal share. And so this further constricts how provider taxes can be used to fund the non-federal share. It also limits an additional cushion payment to providers, known as retroactive coverage. And it limits it. It is, and we'll talk about what it means in a minute, but it goes from being 3 months to 1 month in some instances and 2 months in another. And then it also limits legal payments that states can make directly to providers. And we can talk about examples of those in a few minutes. Okay, so frustrating enrollment. So work requirements will be imposed and required for the expansion population and only the expansion population. So if a state and an expansion population, you don't have to have one. It's not a mandatory group. It's an optional group in the broad rubric of Medicaid policy. So if a state has a Medicaid expansion program, then states are required going forward to condition Medicaid eligibility on participating in qualifying activities that would fall under a work requirement for at least 80 hours a month. And there are a lot of different kinds of activities that traditionally can be used to satisfy a work requirement. It can be working, it can be looking for work, it can be community service to a certain extent, and it can be educational activities to a certain extent. These are all broad categories still as of this date. There isn't specific guidance yet from the federal government about what the details are going to be about what exactly is going to be required for the work requirement and to whom it's going to apply and who is going to be exempted. But these are some general descriptions of what we understand about those requirements. So for exemptions, parents with kids 14 and under, people who are determined medically frail, will be excluded from having to work or satisfy the work requirement. There are some additional details that will definitely continue to frustrate enrollment, which is that as people are applying for Medicaid coverage, they're going to have to verify that in at least one or more preceding months to the application, that they were already satisfying the work requirement. And then another item that frustrates not just enrollment in Medicaid, but also in healthcare.gov individual market plans, is that if someone is denied or disenrolled from Medicaid expansion because of the work requirement, they are also then made ineligible for any financial help that they could have received through healthcare.gov for purchasing an individual plan. So this is expected, the effect to go into effect at the end of next year. And there is a little money for the federal government to give to the states to help them implement it. And there is some wiggle room for implementation dates if a state is making progress and can show that to the Secretary of HHS, then they might be given a grace period so long as they are continuing to make a good faith effort to implement the program in the meantime. New Hampshire has some experience with work requirements in its Medicaid program. It previously attempted to implement a work requirement in the late teens of the 21st century. And in general, it was a complex program and an expensive program to offer. And roughly 30% of the people that were subjected to the work requirement were forecasted to lose their coverage within the first quarter of the program operating. So the program was suspended at the state level. Then it met some legal challenges in federal court and was struck down. However, because the work requirement is now in the statute, in the Medicaid statute itself, that overcomes the legal challenge that had previously been the grounds for striking the program down. So now we're going to go on to increase cost sharing. So the states now have to impose cost sharing of as much as $35 per service on those expansion adults, but the expansion adults with the highest income. So those going from roughly 15,000 to 21,000 will have to pay co-pays. It does exempt services that are considered high value services like primary care, mental health, substance use disorder, and maintains cost sharing for prescription drugs to the fairly modest amounts that are already allowed. In New Hampshire, some Medicaid members have co-pays for prescriptions that range from $2 to $4. And overall, no state Medicaid program could allow someone's out-of-pocket costs to run more than 5% of the household income in any given year. So this cost sharing will go into effect in October of 28, and it also exempts services that are paid for by Medicaid that take place at federally qualified health centers, which are really a backbone of our safety net providers, behavioral health clinics, and rural health clinics. Another way to frustrate enrollment is to increase how frequently eligibility redeterminations are made. So with the advent of the Affordable Care Act, eligibility redeterminations were limited for this population to once a year, once every 12 months, to make the process much more in line with the annual event of open enrollment that many people experience in the workplace, the annual open enrollment for getting financial help on the marketplace through healthcare.gov. And because the assumption was there will be people going back and forth among all of these programs. So reducing the Medicaid eligibility to once a year, or sorry, once every 12 months, because those 12 months could span technically 2 calendar years, was enacted. And so for the expansion population, now states will return to conducting Medicaid eligibility redeterminations twice a year. And there is a little bit of implementation money for states to do this. And this will apply to people having their eligibility redetermined for those that are scheduled for December of 2026 and going forward from there. There still hasn't been guidance issued about the details of that either, but the federal government still has 3 months before it's been 180 days since enactment. Another way that Medicaid enrollment is frustrated is an outright elimination of Medicaid coverage for some legally present immigrants. So I just want to make the point that prior to this statute being enacted, undocumented immigrants were not eligible for Medicaid, Medicare, or ACA products or SNAP. So that has not changed. What this change is removing Medicaid coverage for the following legally present immigrant populations. So people who are refugees, people who've been granted asylum, survivors of domestic violence, survivors of trafficking, and people with very specific visa statuses. There has been a federal policy since welfare reform in the late 90s that said that if there were legally present immigrants who wanted Medicaid, they had to be present in the United States for 5 years before they could access means-tested programs. In other words, before they could access federal programs that rely on measuring your income to determine your eligibility. So these policy changes say, we don't care how long these people, whether they've been here 7 years, like they passed the 5-year bar. We don't care how long they've been here. Now these folks will not be granted Medicaid eligibility. There is coverage that remains for some other legally present immigrant populations. They're on the right-hand side. Again, the effective date of this happens in 2026. Okay, so those were the issues about how Medicaid enrollment will be frustrated in order to reduce spending, because all of those items, work requirements, co-pays, and just outright reducing coverage for groups. The first two, we know from the literature, reduce enrollment in Medicaid. If people don't have money, they don't go, that they think that they have to owe, they don't go, or they go, and then they get kicked out of the program because for failure to pay. And for work requirements, we know from many states' experiences that people don't necessarily gain financial independence, but the roles of the Medicaid program with the work requirement definitely decrease, because quite often the programs are nearly impossible to administer because the reporting requirements are very detailed and they are very specific to different groups of people because of all the exemptions. For example, in New Hampshire spent close to $6 million exhaustively attempting to communicate with members about what they needed to do in order to comply with the work requirements. And even with all of that activity, the percentage of people who failed to understand what the requirements were and follow through with them was significant. Okay, so now we're going to move on to how the changes to Medicaid limit state financing options and provider payments. So we talked about how there's the FMAP, the fixed financial participation, FFP or FMAP, which is that fixed percentage of cost the feds always bear. But that means that there's a non-federal share that states have to generate to have a Medicaid program. And there are some rules about how states can generate that non-federal share, and conditions about provider taxes. Conditions like provider taxes have some pretty specific requirements. So these changes say states cannot establish any new provider taxes beyond what they already have, and they can't increase the percentage rate of the existing tax. So New Hampshire has something called the Medicaid enhancement tax. It is levied on all of the hospitals of our state. It generates hundreds of millions of dollars for the non-federal share every year. And I think it's currently set, I want to say, at roughly about 5.3% of the targeted income. So what this change will do is say that provider tax rate can't increase any further, and the state can't pursue any new versions of provider taxes. And then it also reduces the permissible rate of that tax, so that it comes down to no more than 3.5% in 2032. So it will start to reduce the Medicaid enhancement tax rate by 0.5 percentage point every year, starting in fiscal year 28 until 2032. The states do have around 3 fiscal years to make this transition. And there are some implementation dollars available to the states to guide them through making these transitions. Okay, we also talked about payments to providers being frustrated. There's something called retroactive coverage in Medicaid, and it has been utilized as an incentive to pay providers to encourage them to see Medicaid enrollees. So retroactive coverage means that if someone is seen, for example, at a hospital, and they are determined eligible a month after they started receiving services from the hospital, the hospital can seek reimbursement for 3 months for services provided to that same person 3 months prior to when they were determined eligible, right? To sort of soften the blow and encourage providers to continue to see Medicaid enrollment folks, Medicaid enrollees, that is. So retroactive coverage will go from 3 months to 1 month for any expansion enrollees, and it will be limited for the rest of standard Medicaid or traditional Medicaid from 3 months to 2 months. And all of that is expected to start in 2027. And then another way that states will be limited in how they can pay providers is that HHS will be revising the rules around something called directed payments. So directed payments are payments that a Medicaid program wants to send to specific providers, for example, to encourage certain kinds of services, right? Where they say, well, for these 3 years to really get you going on this new service, we'll pay you at this rate. And it might be above what the standard rate is for that eligibility group or for that service. And these rules say that there can't be state-directed payments for more than Medicare payment rates for states that have expanded Medicaid, or 110% of Medicare payment rates for states that haven't. So an example of state-directed payments could be when you're in the midst of an opioid crisis and you are trying to encourage the provision of SUD, substance use disorder treatment, you might offer a sweetener, right? A state-directed payment to those specific providers to get them to help finance them, to get them on board and offering an online and delivering services. And this would limit the rate at which a state can do that. There is the capacity within this rule for grandfathered payments, so payments that were already enacted as of the time that this statute was passed, can continue, but it will reduce those payments by 10 percentage points each year, starting in 2028, until they reach the Medicare allowed limit that's specified. So in New Hampshire, any state-directed payments will have to come down to 100% of Medicare because we have a Medicaid expansion. And they'll have to do that. That reduction of 10 percentage points each year will start in 2028. Okay. There are also some provider limitations. There was a rule that would have required long-term care facilities to have minimum staffing ratios. And the Secretary of HHS is now prohibited from implementing or enforcing this rule in any way until 10 years after the enactment of this bill. There are certain provider types, primarily Planned Parenthood, who will not be allowed to receive Medicaid funding any longer. There are some bright spots, and I promise we're almost done, and then we can get to the discussion. There's a Rural Health Transformation Fund, which is $50 billion. And it's available to all of the states, and it's going to be distributed this way. Half will be distributed equally among the states that have approved applications, and half will be distributed to states based on an approach that CMS has determined. So guidance for this has come out that all the states are working on this application right now. If you do the arithmetic, $25 billion divided equally among the 50 states is $500 million. So that's the baseline that New Hampshire is eligible for with its application, $100 million every year for 5 years. That's the minimum it can receive. So that's the baseline funding we see here, right? And then the other half will be the workload funding, which is based on a combination of factors about the density of the rurality, whether or not the state got approved for the baseline application, and then different metrics and state policies and that align with what is in the application for states to fill out. So the states have to submit this application by the 5th of November. So we have less than 4 weeks to go. and federal HHS has to approve or deny those applications by the 31st. Here are the types of activities that the states have to carry out with the awarded funds. These are all excellent initiatives. There are some parameters around unallowable costs that might increase the challenge to the state. So in terms of utilizing these dollars effectively, first and foremost is the requirement that every state has to spend all of the money that they are awarded in the first year before they can have access to all of the funds awarded in the subsequent years. Failure to spend all of those dollars within that time frame will mean that the state has less access to that amount of payment in future years. And the regulations have specified that the federal government doesn't mean that these funds be encumbered or subject to contract, but that the contract is executed and that the payments to the vendor that's been contracted go out of the state coffers within 1 year, within 12 months. That's a very big timing challenge for the state administration. Other requirements around or limitations on what are unallowable costs. New construction would not be allowed. These funds cannot replace payment for clinical services that could be reimbursed by insurance. And the application will also not be approved if the use for the payments is for clinical services, if they duplicate currently billable services and or attempt to change the payment amounts of existing fee schedules. So if a state plans to fund direct healthcare services, they have to justify why they are not already reimbursable, how the payment will fill a gap in coverage, and or how they transform the current delivery model. And funding for provider payments, subject to all of those things that we just talked about, can't exceed 15% of the total funding award to the state. Also, you can't spend all of your money on an electronic health record. No more than 5% of total funding could go to the replacement of an EMR system. Those are some challenges. The other bright spot is that there is a new long-term care waiver authority, which essentially allows states to provide services to folks who don't yet require a skilled nursing facility level of care, to keep them from having to proceed to having institutional level of care for services. And that waiver opportunity is available at the end of July of 2028. Okay, so to put a fine note on it, these changes, the One Big Beautiful Bill Act, that's in purple on this slide, came at the same time as a new state budget for the state of New Hampshire. And this New Hampshire state budget had multiple changes to Medicaid also. And those are the priorities in green. So the state constructed this timeline so that folks can see what their federal requirements are, what their state requirements are by year as it relates to the Medicaid program. It feels like it's 2026 already from an implementation point of view. And you can see that the state has its own work requirement that it's required to act on. There are some differences between the state work requirement and the federal work requirement. They're going to have to get worked out, and that the state is currently trying to align with the federal requirements. Perhaps ironically, the state work requirements from our prior waiver experience are more, at least to the extent that we know details, are more stringent than the federal requirement for work requirements. There's a copay increase at the state level for Medicaid prescriptions. There was also a desire to impose premiums for some people in Medicaid. Also, again, perhaps ironically, OBA, the federal bill, when it imposed the $35 copay for a variety of services, prohibited imposition of premiums on members. So again, the state has some alignment to work out what it is directed to do under state law and what it may do under federal law, and how to bring those two into alignment. So I'm going to stop there. This is my email address. I'm going to stop and say, okay, what would people like to talk about?
Thank you so much, Deborah, for that comprehensive analysis. There's so much there to digest on a rainy Wednesday morning. So thank you. We do have some great questions in the chat. And I really want to start with a broad question before we get into the weeds about specific details. Yep. This question comes from Beverly Pietlicki, and apologies if I mispronounce your name. She wrote, this sounds like state control. I thought they were all about giving control to the states. And I want to piggyback on that because it does sound like states are incredibly constrained in what they can do and how they can respond to these changes. I wonder if you foresee a period of innovation, or do you think that there are so many constraints here that it might actually prevent some innovation at the state level?
I think difficult environments always create opportunity. I would say, yes, I do think it will provide some opportunities for innovation, and the financial pressure that's going to be put on the state program because of the changes to how it may finance it, the non-federal share, and the limitations that it's going to put on how the additional payments it can provide to providers are going, I would think, would eventually cause the state to have to find some innovation to allow it to continue to the program as it currently is. So it is, there are a lot of new requirements and limitations. And like I said, I think that there's always the possibility that difficult environments create opportunity. But I think there is an equal measure, a lot of financial pressure that's going to be applied to this program, and not instantaneously, but 2027 and 2028 may be very difficult years for any Medicaid program, including the one in New Hampshire.
Okay, thank you. A question from Navy Hung. What do you think about the pressure this Medicaid bill puts on hospitals? How much do you think it could reduce clinical placement opportunities, maybe as a percentage? And she's interested if there's been a study on how this might affect CHHS.
Well, I think hospitals will face increasing pressure around uncompensated care. They will have to, by mission and for many folks, by directive of their institution, will have to continue to provide services to people who come to them. But they will experience increasing financial limitations in order to participate in Medicaid. And the frustration in enrollment subjects them to increase uncompensated care, not in addition to the limitations on provider payments. because folks may not be able to comply with the requirements of the program, but they will still get sick and they may still seek care, especially if it's an emergency, in which case, if someone shows up in the emergency department and they didn't understand the work requirements, and so they were disenrolled from Medicaid because of the work requirement, which means they also now cannot get financial help in the marketplace. They have no reimbursement method for that provider to key into to be reimbursed for their time and services to that person. And we already know that the hospitals financially were severely strained due to the COVID pandemic. So I think it just further increases the financial pressure on them.
Well, that's not good news. A question from John Rodat. John asks, do I recall correctly that New Hampshire experimented with a Medicaid work requirement? And you actually mentioned this in your presentation, and you mentioned that it was complex and expensive, and there was a lawsuit, and it was ultimately suspended. Yep. He's asking what was the result and what did we learn? I wonder if you could expand on what we learned from that.
So the lessons of work requirements for Medicaid programs, I would say that what New Hampshire learned is that it's expensive to administer. It's very complex and difficult, almost impossible on some level to administer in a way that doesn't interrupt enrollment. And it's expensive, but doesn't yield savings to the state necessarily. Because even though people fall off the Medicaid rolls, as we were just discussing in terms of financial pressure for the hospitals, uninsured folks are still uninsured folks in New Hampshire. And the state still pays to the hospitals DSH payments. They're designated disproportionate share hospital payments, which are intended to provide them with some compensation for uncompensated care. That only increases. So I would say work requirements don't necessarily increase work, don't necessarily increase employment, and they don't necessarily improve financial outlook for members. But what we do know is that they are very expensive and very complicated to administer, and that they do, in fact, depress enrollment.
Okay, thank you for that. A question from Tasha Broder, and this may be the last one, depending on time. Does the Rural Health Fund 100% annual spending expectation continue year to year or just year one? And can you give a brief breakdown of the 2017 tax reductions that are being extended?
I am not a tax expert. I cannot give a breakdown of the tax reductions other than to say that their total value is in the trillions of dollars, $5.3 trillion.
And the first part was about the Rural Health Fund and spending expectation. Does it continue year to year or just year one?
So you have to get an approved application. If your application is approved for the full $500 million, then you get access to that $100 million in the first year. If the state does not spend all of that money in that 12-month period, whatever is still remaining goes back into an undistributed pot. And the state now, like, for example, what if New Hampshire was awarded $110 million year to year, and in the first 12 months, it only spent 30 million goes back into the pot, and year two, New Hampshire only gets access to 80 million. So there's a lot of incentive for shovel-ready, very, very quick implementation projects.
Interesting. Okay. So unfortunately, we didn't get to all of the questions and we're out of time, but I want to remind you that this recording will be posted in a few days on our Carsey Policy Hour webpage. So please do go back to the recording and review these slides and this presentation Thank you so much, Deborah, for sharing such a comprehensive analysis. There's so much there to unpack. I wish we had 2 hours to talk about it. And thank you all to everyone who joined us today and contributed really thoughtful questions and discussion. Our next policy hour is on Wednesday, November 12th at 8 a.m. So we will see you then. Thank you again. Have a great day.